positive symptoms are things that you may gain, obviously not in a good way. Things like things you may not have had from before, such as hallucinations, abnormal thought, delusions, and agitation or excitement. Okay, so negative ones would be things like obviously social withdrawal, blunted emotional effect, and thought blocking. Okay, now hallucinations, that's defined as false perceptions that occur in any senses, but most of the time it's to do with auditory. That's an ear, by the way. Look, ear. Alright. And delusions are basically strongly held beliefs that have no actual basis in real life. The brief psychiatric rating scale, and that's basically comprised of like 18 symptoms that you choose from, and each symptom is basically rated on a scale of 1 to 7, from this one being absent and this one being severe. In terms of the positive and negative syndrome scale, it's exactly the same except there's 30 items, and the 1 to 7 scaling is from absent to extreme. This is the clinical global impressions, and that's basically a chart, and it shows you like the efficacy of drug treatments. Yeah. Alright. AIMS, this is the abnormal involuntary movement syndrome, and that basically comprises of 12 it's a 12 scale 12 item scale list, and basically this accounts for drug induced symptoms such as tardive dyskinesia. There is a correlation with smoking a joint, cannabis, and psychosis. So this little chap here, his name is Brad, okay, and he's smoking his joint, and he's got his whole red eyes and all that crap. Now, the actual cannabis itself has a chemical called delta 9-HTC. Okay? Is that HTC? No, it's THC. Sorry about that. Okay, so it's delta 9-THC. Alright? Now, this particular chemical is basically what gets you high. Yeah? So, if you want to be looking like that, that's basically what you need to be taking. Okay? Now, because of that, this causes things like paranoia, blunted effects like reduced emotion, reduced interaction. You're kind of in your own world there, and that leads to a 2.5 times more likely chance of being diagnosed with schizophrenia. 4 pathways in the brain, okay, and they all act somewhere, and they're all got different names. Okay, so we've got a mesolimbic pathway now. This produces way too much dopamine, okay, and that is what gives you your positive symptoms. Yeah. And then you've got your mesocortical, which doesn't produce enough dopamine, and that's what gives you your negative symptoms. Okay. Alright, you've got a nigrostriatal dopamine pathway. Obviously you've got the substantial nigra, and then you've got the basal ganglia. Yeah. Now, an effect on these are going to cause extra extrapyramidal side effects. Okay, I can't bother to write down. Okay, now extrapyramidal, is it pyramidal? I think it's pyramidal. Extrapyramidal side effects include things like acute dystonia and tardive dyskinesia. Okay, now acute dystonia, that is basically when you have involuntary movements, and you've got tardive dyskinesia, and that's things that that's basically disabling, and that occurs like as a cause as a result of antipsychotic drugs. And if you stop antipsychotic drugs, it gets worse, and it has a resistance to treatment as well, so you can't really cure it either. In the mesolimbic pathway, you have too much dopamine being produced, or coming through even. If you have too much, then you have positive symptoms. And the way that happens is, in the mesolimbic pathway, we have a lot of D2 receptors. Okay? These D2 receptors basically allow the dopamine to just come through. Yeah? Okay, that's pretty straightforward, I think. Now, we get on to the mesocortical. Okay, what we've got is we've got delta 2 here, D2 receptor, sorry, which also allow dopamine to come through. But what we also have is we have a little receptor here. Well, we've got a few receptors here. Obviously, they have to come out from somewhere, don't they? So these receptors, they're called NMDA receptors. Okay. And what this 5-HT2 does, okay, there's different types of 5-HT2s. There's 5-HT2A, 5-HT2C. 5-HT2C is going to cause weight gain. 5-HT2A is kind of like what they really want to act on, though. I'm going to stick with 5-HT2 right now. So what happens is the 5-HT2 will come here and act on these. Now, by acting on these, it changes them and alters them, and basically means that this dopamine can't come out. They have nowhere to come out from. Does that make sense? So the dopamine can't come out, so it can't attach to the D2, and it can't go through. Does that make sense? So because of that, you're going to have less dopamine in the mesocortical, and therefore that's why you get your whole negative symptoms. Yeah? Okay, now we have a number of drugs to help with all that stuff. But first I'm going to go into one more thing, which is what dopamine does usually is this. Let's say these are dopamine, okay, because I can't want to put DA. And what happens is they will go through into the postsynaptic neuron, and what they would do is they will inhibit acetylcholine on the other side, because they have relations with acetylcholine in the nigra striatum, and what they'll do is they'll stop the acetylcholine basically leaving this neuron. Yeah? So by doing that, obviously, by doing that you have less acetylcholine, and in schizophrenia you don't have that happening. So obviously, by having something like an antimuscarinic, which blocks the effects of acetylcholine by acting on cholinergic receptors, acetylcholine isn't going to come out. This is your mesolimbic, and we said in mesolimbic, if you have an increase of dopamine, you have an increase of dopamine coming in. Therefore, you have your positive symptoms. Okay, so what we want to kind of do is decrease the amount of dopamine. Okay, this is dopamine, by the way. Okay, and in your mesocortical pathway, we have not enough dopamine coming in because of the 5-HT2 receptor basically blocking the NMDA receptors here. Okay? Therefore, dopamine can't come out. Okay? Now, we have two types of drugs. We've got typical and atypical. Typical is the ones pre-1990, they're the first generation, such as chlorpromazine and haloperidol. And then you've got the atypical, such as clozapine and risperidone. Okay. Now the typical, they mainly act and have a higher affinity for D2 receptors. Now, what they would do is they're going to antagonize these receptors here. Okay? So by antagonizing these receptors, you're going to have the dopamine not being able to get through. Yeah? So you're going to have less dopamine coming in. Pretty simple. However, these aren't, they're not specific. The typicals are not really specific. So they also act on the mesocortical D2 receptors and also stop the dopamine getting in here. Now, we already have a decrease of dopamine as it is. So if you have a further decrease, you're going to have further negative symptoms. Yeah? Now, in addition to all that, it also acts in the nigrostriatal pathway, and it also inhibits the D2 receptors there. And by inhibiting dopamine release in the nigrostriatal pathway, you're going to have Parkinson-like symptoms, such as the extrapyramidal side effects. And that's going to consist of, obviously, the acute reversible dystonia and the tardive dyskinesia. Yeah? So, they do act slightly on 5-HT2 and act to inhibit these, but not as much as atypicals. And what they do, the atypicals, such as clozapine and risperidone, now they don't act as much on D2s, they act mainly on the 5-HT2s. And what they'll do is antagonize them. Therefore, they won't be able to, the 5-HT2 won't be able to antagonize these. Therefore, dopamine can freely come in. Yeah, okay, some of the D2 receptors will be blocked because it does have some kind of antagonism effect on the D2 receptors, but not all. So you still have more dopamine coming in the mesocortical, therefore your negative symptoms are going to decrease. In terms of over here, obviously it does have an affinity for the D2 receptor, therefore obviously you're decreasing the dopamine coming in. Okay? But because it doesn't have a high affinity for D2, it also doesn't have a high affinity for the D2 here. And if it doesn't have a high affinity for D2 here, you won't get as much extrapyramidal side effects. And that's why clozapine does have has no extrapyramidal side effects. It does. They both typical and atypical. They both have effects and antagonize alpha adrenal receptors. So you will get things like the typical postural hypotension. They also act as anti-muscarinic effects by, obviously, as before we just said, they block the action of acetylcholine. Therefore, you won't get the whole imbalance between acetylcholine and dopamine. Therefore, you won't have as much bad cognitive effects. The trouble with clozapine, though, it does have its disadvantages. It does reduce neutrophils, so you do need to have full blood count regularly. It increases seizures and increases anticholinergic side effects. And because it also acts on 5-HT2C receptors, it also increases weight gain. The same goes with risperidone, but the only difference is that extrapyramidal side effects do happen in high doses. Now, with chlorpromazine, I think that's right, you will also get, with all of them you also get sedation, and with chlorpromazine, you also get obstructive jaundice. Um, Whereas with haloperidol, you won't get obstructive jaundice and you won't get sedation. And in terms for the anti-muscarinic effects with haloperidol, it's not as much.